You are examining a cyanotic neonate. Determining whether you are facing a structural heart defect or a mechanical lung failure requires stripping away the clinical noise. This diagram shows the physiological transition at birth. Clamping the umbilical cord spikes systemic vascular resistance, and taking that first breath drops pulmonary vascular resistance. If this precise pressure balance fails, deoxygenated blood bypasses the lungs. The infant turns blue, and a neonatal crisis begins. Recognizing which side of this pressure seesaw failed dictates exactly whether the neonate requires immediate surgical intervention or mechanical ventilatory support. To separate the primary cyanotic heart defects, we use a framework looking for pulmonary blood flow obstruction versus parallel circulation. Here is our comparative data table. Tetralogy of Fallot typically presents with a boot-shaped heart, while transposition of the great arteries shows a silhouette like an egg on a string. This diagram shows transposition of the great arteries. The aorta connects directly to the right ventricle, and the pulmonary artery to the left. This creates a closed parallel circulation problem, resulting in severe, immediate cyanosis within hours of birth. Contrast that with this diagram of tetralogy of Fallot. Notice the right ventricular outflow tract obstruction and the overriding aorta. Because the obstruction severity varies, the cyanosis in these infants is usually delayed and episodic. Those episodes are known as TET spells. When the infant cries, oxygen levels drop, the outflow tract spasms, and deoxygenated blood is forced across the ventricular septal defect. Bringing the knees to the chest mechanically kinks the femoral arteries. This artificially raises systemic vascular resistance, generating enough left-sided pressure to force blood back into the lungs. Memorizing that squatting helps is a fragile strategy. Understanding how the maneuver manipulates systemic vascular resistance to override an anatomical blockade allows you to manage the underlying hemodynamics. If the cardiac plumbing is intact, we transition to respiratory distress. This splits into two distinct mechanical failures: a deficiency in surfactant, or a failure to clear fluid. This chronology map outlines transient tachypnea of the newborn, or TTN. It strictly follows term C-sections because the infant misses the physical thoracic squeeze of a vaginal delivery. Tachypnea begins within minutes and typically resolves by 48 hours. We triage these lung mechanics failures on a specific scale. Stable cases need observation, emergent cases require CPAP or artificial surfactant, and critical cases demand ECMO. This graphic shows the visual footprint of respiratory distress syndrome. Without surfactant, alveolar compliance drops, creating these diffuse, grainy opacities. This represents an emergent failure. Now look at this chest X-ray of meconium aspiration syndrome. Instead of a uniform texture, we see coarse, irregular infiltrates and hyperinflation. Thick particulate matter is physically obstructing the airways, indicating a critical presentation. When a newborn is tachypnic, recognizing the specific radiographic silhouette dictates the exact level of invasive mechanical intervention required to save them. We evaluate normal developmental maturation along two primary axes: cephalocaudal, meaning head to toe, and proximodistal, meaning from the core to the extremities. This timeline maps a normal, steady trajectory down those axes: a social smile at 2 months, rolling at 4, sitting at 6, crawling at 9, and walking by 12 months. The absolute red flag in pediatric milestones is regression. The loss of a previously attained skill demands immediate neurological evaluation. Let's test your visual pattern recognition. We have 3 unlabeled silhouettes: a boot-shaped heart, a ground glass lung field, and perihilar streaking. The boot indicates tetralogy of Fallot, where severe cases need prostaglandins. Ground glass marks respiratory distress syndrome, requiring surfactant. And perihilar streaking is TTN, managed with observation. Identifying the anatomical defect visually is the most reliable way to avoid the trap of overlapping clinical symptoms. Let's run a final validation drill using 2 clinical vignettes. Your goal is to filter the noise and map the correct chronology. Vignette 1. A term neonate delivered via C-section presents with grunting. Radiography shows fluid in the interlobular fissures. Isolate 39 weeks, C-section, and fissure fluid. This maps cleanly to transient tachypnea of the newborn. The answer is observation and supportive care with oxygen. Vignette 2. An infant turns blue crying, but pinks up when holding knees to their chest. The X-ray reveals an upturned cardiac apex, identifying a TET spell. The color improves because knees to chest creates shunt reversal by increasing systemic vascular resistance. This master matrix combines our frameworks. Use the timeline to divide cardiac plumbing issues into immediate or delayed, and match lung mechanics to the precise radiographic silhouette. Clinical mastery is achieved by applying first principles physics and mechanics to cut through the noise and save a life.